Okay. I would like to welcome everybody to our May webinar. This is going to be our last webinar of the semester, and then we'll be kicking it off again in September with our first webinar of next semester being on September 4th. Tonight we are going to be hearing about pandemic flu planning, and we are really excited to have Aggie Serrame, who is currently employed at the National Institutes of Health as an emergency management specialist. She's responsible for creating emergency plans and policies for the entire agency, and her main work at NIH is pandemic flu planning and leading the agency's COOP program. She received her BA in political science from Elizabethtown College, her first master's degree in Homeland Security, public health preparedness concentration from Penn State, and we are so excited to have her back. And she also got her MS in Biohazardous Threat Agents and Emerging Infectious Diseases from Georgetown University. So, Aggie, thank you so much for putting this together for us, and we are really excited to hear about pandemic flu planning tonight, so thank you.
Thank you so much for having me, and for everyone online, thank you for listening to my lecture. I know it's pretty late, so I really appreciate having everyone here. So we're going to go ahead and start so we can get a head start on this and not be too late. Like Jen said, my name is Aggie and I work for NIH. Most of my work is in pandemic influenza and planning, and I'm going to talk about here some concepts in pandemic influenza and as well as a little bit of the planning side within the federal government. First, just a little overview on influenza. Influenza or flu, as we know it, is a contagious respiratory illness, usually caused by an influenza virus and usually infects our nose, throat, and also our lungs. A lot of people don't know that there are 4 types of influenza viruses. There's types A, B, C, and D. Most people are only familiar with type A, but actually if you go and have a test at your doctor's office, they can actually tell you what type of flu you have if you get diagnosed. Type A is usually responsible for the majority of all the seasonal flu cases every year. It is found in humans and animals, and it spreads from one person to another by an individual who is already infected by the flu. Type B is another type of the flu that causes seasonal illnesses. It is only found in humans. It has the potential to be very dangerous, but it's typically less severe than the type A flu. It does not cause pandemics unlike type A, and also there are different strains of the type B influenza, but there are no subtypes unlike influenza type A. Type C is milder than types A and B and only affects humans. Most people who are infected by the type C influenza virus will know that they have some strain of the flu virus because the symptoms are very similar to those of a cold. And lastly, type D, which a lot of people are not familiar about, are known to only infect pigs and cattle, and no human infections have been seen with this one. And now, the CDC, or Centers for Disease Control, estimates that the flu resulted in between 9.3 and 49 million illnesses each year in the United States since 2010. So that's a pretty big number right there. So I think this slide here shows a perfect comparison of a cold and a flu. A lot of people, when they go to a doctor, they honestly have no idea if they have the cold or the flu. And these are some of the symptoms, and you can see it's very, very, very similar. So the thing that stands out to me is the first row that says symptom onset. So with the cold, you can gradually feel that you're getting sick. And with the flu, it's very abrupt. So I got the flu in 2017. So in 2017, a lot of the science research showed that the vaccines were not effective. It's because there was a new strain of influenza A virus because of the whole drift that had happened. And so what happened to me was that I was fine during the day, and I went to work, and then I came home and I just felt like death. And if you've had the flu, you know exactly what I'm talking about when you feel like you're in your deathbed. So these are just some of the comparisons of the cold and flu to see if you have any of these symptoms. Always make sure to visit your physician and get diagnosed. So most of the people who will get the flu will usually recover in a few days, usually less than 2 weeks. The cold is usually actually longer than 2 weeks. Some people can develop complications since it affects your lungs. You can also develop pneumonia. If not treated, the flu may cause death. And this fourth bullet is very common with children. Sinus and ear infections are also the moderate complications from the flu. And there are other serious complications from the flu, such as the inflammation of the heart, the brain, muscle, and sometimes a multi-organ failure. People with asthma may also experience asthma attacks more than normally. And people with chronic heart disease can also experience a worsening in their condition. Any of these symptoms occur to you or anybody, it's always best to consult a physician and see a doctor and get diagnosed. So for this next few slides, we're just going to talk about a little bit of the virology of the influenza virus. Not too much science into it, but this part is very important to looking at how a pandemic is created. So the Influenza A virus, which you can see on the image on this slide, which is the purple with the blue spikes, the virus is divided into subtypes on the basis of 2 proteins. There are 18 known H subtypes and 11 known N subtypes. The proteins are seen in the blue in this image. They are the spikes around the virus. Both of these proteins are required in order for the virus to be infectious. So, you know, basic biology, when the virus goes inside your body and goes inside a cell, it replicates itself, and that's how you get sick. There are many different combinations of the H and N. All known subtypes of influenza A viruses can infect birds, except 2 subtypes that are only been found in bats. We are going to look into that a little bit later. And only 2 influenza A virus subtypes are currently in the general circulation among the human population. And you're probably familiar with one of them, which is H1N1, and the other one is H3N2, which we are going to talk about a little bit later as well. There are 14 versions of the H protein and 9 versions of the N proteins. This create, all in total, it's going to create 144 varieties of the flu. But it is important to note that not all of these 144 varieties are infective to us humans and to animals. For example, H7N7 and H3N8 virus infections can cause illness, in horses, and H3N8 virus infection can cause illness in horses and dogs. So dogs can also get the flu. So the next 3 slides, I'm just going to kind of quickly flash. These are the type of subtypes of the influenza A. So you can see here, and there's a number correlated to a certain subtype and what species they affect. So you can see here, it's pretty much all poultry, and then humans, and then pigs, and then other animals. And like I mentioned earlier, there are only 2 found in bats, and they have not been found to infect human or other animals. They're just found in bats. And this is the N subtype. And okay, for this next slide, this is important because this is the processes that can potentially create a pandemic. A little bit of science with the influenza virus. This is a great image that I found online on how it kind of explains to us what happens during the shift and the drift between these different cells or these different viruses. The antigenic drift, which is to the right, is characterized by small mutations of the RNA, and it forms a new strain of virus. It's important to note that this specific process only involves one kind of virus, as you see here. There's only that purple one. This occurs very frequently, and it's actually very common and very spontaneous. This process occurs in influenza virus A, B, and C, those that are found in humans. It usually infects animals of the same species, and it is responsible for epidemics in between pandemics. But the good news is that it can be easily treated with the help of our antibodies if you get the flu shot and medications that are already available out there. And to the left of that is the antigenic shift, which occurs once in a time. And when it occurs, it can actually start a pandemic. This is a very important process with the reassortment of the influenza A virus. It involves one or two viruses, which forms a whole new subtype. And this new subtype created can jump from one species to another, making it extremely difficult to treat because we don't have antibodies for this type of virus. This will require, and because of that, this will require a development of a whole entire vaccine. And now if you've done research with vaccine development, it takes a long time for vaccines to be developed. It goes through different phases of trials within science research. Within my agency at NIH, we have an institute solely responsible for doing flu research, and I was told that a vaccine can take up to a year to be developed. So that's a long time to wait if there is a pandemic going on. It's important to note that this process only occurs with the influenza A virus, so it doesn't happen with the other types of virus, such as B, C, and D. An example of the antigenic shift is the 1918 pandemic, when the H1N1 avian strain mutated, and it enabled the virus to be rapidly and efficiently transferred from human to another human. So now we're going to talk about avian influenza AI, or most commonly known as the bird flu by many. It's caused by the avian influenza type A viruses. This usually occurs in wild aquatic birds such as ducks, geese, and so forth. The bird flu can infect other domestic poultry and other species, but it does not normally infect the human species. It is, however, possible for humans to get infected by the bird flu, as we've seen before. And we've seen this a lot in other parts of the world, such as in Asia. Most of the people who get the bird flu have had close contact with infected birds or with surfaces that have been contaminated by the bird's saliva, mucus, or droppings. The biggest threat that involves the bird flu is the movement of migratory birds who are infected by the avian flu. Now, there's a lot of research that you can actually Google with the migratory birds and how supposedly there's a threat that they're going to bring bird flu into North America. So that's something that we've been working on at NIH as well, doing research with our Environmental Health and Sciences Institute. You might also be wondering if this type of influenza usually infects birds, then why do we have to worry about it? There are two issues we have with migrant birds coming to North America. The first one is that they can infect the domestic poultry population in the United States, which can actually be a larger issue with our poultry supply, which that is the biggest threat. And that leads into like agroterrorism and all that other stuff. And then the second one could be the virus might mutate and maybe transmitted from the migrant birds and then to the domestic birds and then to humans. And then the influenza virus can mutate again and enable the virus to have human-to-human transmission capability. And this can potentially be a really, really bad pandemic. And with avian influenza, the avian influenza A viruses are designated as highly pathogenic avian influenza, or HPAI, or low pathogenic avian influenza, or LPAI, based on their molecular characteristics of the virus and the ability of the virus to cause disease and mortality in chickens in a laboratory setting. High path AI and low path AI designations, they do not refer to the severity of illness in cases of human infection with these viruses. Both low path and high path viruses have caused severe illness in humans, however. Most strains of the avian influenza are not highly pathogenic, and they cause few signs of disease in infected wild birds. However, in poultry, some of the low path can mutate into high path avian influenza strains that can cause contagious and severe illnesses among poultry. And sometimes in wild birds, they can cause death. The effect is dependent on the viral strain of the influenza as well as the host species, so what kind of birds they are. Avian influenza is actually very common, but a few instances of birds infecting humans have occurred in the past. It's very rare, but it's not impossible. The transmission from animal to human creates the whole reassortment of the RNA or the antigenic shift, which creates the bigger problem. Once a person is infected by a non-human influenza A strain, it is possible for a human-to-human transmission. And like I mentioned earlier, this creates the biggest threat of a pandemic event. So now another thing that we're going to talk about is the swine flu. The swine flu viruses can cause high levels in swine herds, but usually cause few deaths. Common signs in sick pigs include fever, depression, coughing, and so forth. Pigs that are infected by the swine flu may not appear ill or can appear as mildly ill. So you won't even know if they're sick or not. They're asymptomatic. Most of the swine flu outbreaks occur during the late fall and the winter months of the year, which is challenging because it's a similar timeline as the seasonal influenza outbreaks in humans. The swine flu usually does not infect humans. However, sporadic human infections with the swine flu have occurred in the past. Humans are infected by the swine flu if they have been in contact with pigs that have the swine flu. Humans do not contract a disease by eating a pig with swine flu. That's a myth. The biggest H1N1 event recorded in history was the 2009 pandemic, which we're going to discuss a little bit later. So just a few numbers with the flu season. This past flu season, from October 1st of last year to April 13 of this year, just a couple of days ago, there have been 36 to 41.3 million flu illnesses recorded, 16.7 to 19.4 million flu medical visits, and 502,000 to 610,000 flu hospitalizations, and 34,000 to about 57,000 flu deaths just recorded from this flu season. It's a pretty high number. And one way to prevent that, as we all know, the seasonal flu vaccines. Usually the seasonal flu vaccines have different strains inside of them. So with the strain that we're getting every year, we always have an Influenza A H1N1 strain in there. We also have the Influenza A H3N2. So H1N1 is the bird flu and H3N2 is the swine flu. And then usually they'll add one or two Influenza B viruses depending on what the science says for that year. They're always included in each year's influenza vaccine. So it's not just one strain, there's a couple strains in the vaccine. And fortunately, a vaccine has been developed for individuals with egg allergies so that they can also get the benefit from the flu vaccines. I've included a chart from the CDC, which you can see on the right, just numbers of flu vaccination coverage in the United States. So as you can see, with children between 6 months to 17 years old, about 59% of children in the United States have received the vaccination in 2016 to the 2017 flu season. Although this is a good number, it's not high enough to achieve herd immunity. For example, before the use of measles vaccines, every person with measles would infect another 10 to 15 people. And so that's how the disease spread very quickly. And we are seeing this same trend right now with the current measles outbreak in the various regions of the United States. There's actually a couple outbreaks right now in Maryland where I work. The concept of herd immunity stops the spread of vaccine-preventable infectious diseases such as measles, chickenpox, flu, and etc. It is the idea that when many or most of the population is vaccinated from a disease, they will not be able to contract the disease and they will not be able to transmit it to another person. However, there is still a big debate with the use of flu vaccines with the increased popularity of the anti-vaxxer movement. This movement do not believe in the efficacy of the influenza vaccines as well as other vaccines available out there. So we've been dealing a lot with the anti-vaxxer movement with my agency, and it's very political, so we're not really going to talk about that. But you can go online and read a lot of articles about it and how different science agencies are handling misinformation online. Just a little information on epidemic versus pandemic. A lot of people get confused but are afraid to ask. Epidemic is a disease that occurs with a greater frequency than expected. An example of an epidemic would be the current opioid crisis we are having in the United States. It's actually labeled by HHS as an opioid epidemic. So we've been actually working on that as well, especially HHS. And pandemic is an epidemic that spreads all over the world or a major region of the world, which would be a pandemic influenza as an example. So for seasonal influenza, it's very common during the fall and winter months of the year. As you can see the chart here, this is kind of like the range of the flu season. A lot of people are surprised that it actually starts in October and it can last as late as May, but the peak months of influenza activity is usually December and February. It's a really good preventative measure to get your flu shots in the earliest times of the flu season, because your body has time to develop the antibodies that it may need if you come in contact with the flu virus. When I actually got the flu virus in 2017, I remember that I got it right after I got the flu shot. So I had a lot of theories why I got it, but at the end of the day, I was so glad that I got it because my flu only lasted for 5 days instead of 2 weeks. So influenza pandemic, it's a global outbreak of a new influenza A virus that is very different from current and recently circulating human seasonal influenza A viruses. So it's a new influenza A virus that we've never seen before. We don't have any immunity and we have no vaccines for it. Influenza A viruses are constantly changing, making it possible in very rare occasions for non-human influenza virus to change in such a way that they can infect people easily and spread efficiently from person to person. And that's something that we don't want. And now we're going to talk about the influenza pandemics of the 20th century. The most infamous 1918 Spanish flu was caused by an H1N1 virus, an avian influenza. There is no definite source where the virus originated, but the virus spread worldwide from 1918 to 1919. In the United States, it was first identified in military personnel in spring of 1918. And now I forgot to actually look up where the military personnel were located, but I have a feeling that they were overseas, and that's how it spread to the United States. It is estimated that about 500 million people, or 1/3 of the world's population, became infected with this virus. It is the most fatal event in human history, and about 50 to 100 million people died all over the world from the 1918 Spanish flu. And in the United States alone, there is 675,000 fatalities. So a couple years later is the 1957 Asian flu, H2N2, which emerged in East Asia, hence the Asian flu name. And the H2N2 virus was comprised of 3 different genes from an H2N2 virus that originated from an avian influenza A virus. This was first reported in Singapore around February of 1957, and then a few months later in Hong Kong in April of 1957, and then it was found in the coastal cities of the United States in the summer of 1957. So it didn't take long for the flu to come to the United States from Asia. The estimated number of deaths was 1.1 million worldwide and 116,000 people in the United States. And a decade later was the 1968 Hong Kong flu, H3N2. This virus was comprised of 2 genes from an avian A influenza virus, including there was a new H3 hemagglutinin, which is the H part, but also contained the N2 from the previous pandemic. So that's where the reassortment came that we talked about earlier. The estimated number of deaths was 1 million worldwide and about 100,000 in the United States. Most excess deaths were in people 65 years and older. The H3N2 virus still continues to circulate worldwide as a seasonal influenza A virus. Seasonal H3N2 viruses, they are associated with severe illnesses in older people and always undergo regular antigenic drift. So this is one of the strains that we have in our yearly seasonal flu vaccines. That's a good trivia question right there. And then lastly, the 2009 H1N1 flu pandemic, or as we've known it, the swine flu. Okay. The virus genes were a combination of genes mostly closely related to North American swines and their Eurasian swines. Because of this, the initial reports referred to the virus as a swine origin influenza virus, so they thought it came from pigs, that pigs infected humans. However, with further investigations of the initial human cases, they did not identify these people to be exposed to pigs. And it quickly became apparent that the new virus circulating among humans was only among humans, and it wasn't actually in the American pigs, which is kind of funny. Human-to-human spread swine influenza viruses had been rarely documented and had not been known to result in widespread community outbreaks among people. In mid-April of 2009, only a few years ago, however, the detection of 2 patients infected with swine flu viruses, 130 miles apart, that's only maybe like an hour and a half apart, it raised a concern that a novel swine origin influenza virus had made its way into the human population in the United States, and it was spreading among people quickly. So by April 21st of that same year in 2009, the CDC had begun developing a virus that could be used to make a vaccine to protect against this new strain. They usually call this a candidate vaccine virus. The next day of April 2009, the CDC activated its Emergency Operations Center, or EOC, to coordinate response to the emerging public health threat. And a couple of days later, in the same month, the same year, the CDC actually uploaded complete gene sequences of the 2009 H1N1 virus to a publicly accessible international influenza database. This enabled scientists around the world to use the sequences for public health research and for comparison against influenza viruses collected elsewhere. And an updated report on the outbreak was also published online. So this was a really great work by the CDC. In a couple of days, they were able to sequence the virus, which helped a lot of people around the world, especially the scientists, create vaccines. The series of events in that same month and year continued when the Director General of WHO, World Health Organization, declared a 2009 H1N1 outbreak as a public health emergency of international concern. Now it's becoming a really big deal. It's an international concern. This was on April 25th, so only a couple of days after the detection. And then shortly after, the United States responded. The United States government determined that a public health emergency is existing nationwide, and CDC's Strategic National Stockpile began releasing 25% of the supplies within that stockpile that could be used to protect and treat influenza. So when the stockpile is used, it usually means there's a big outbreak going on that could lead into a pandemic event. This stockpile included 11 million regimens of antiviral drugs. It also included PPEs, personal protective equipment, over 39 million respiratory protective devices, masks, respirators, gowns, gloves, and face shields, and other various equipments. This was deployed to the different states in the country, and the allocations were based on the state's population. So this whole thing prompted a nationwide response to the H1N1 pandemic, but as we see here, response was very quick on the national side of things within the United States. If it had been detected later, the pandemic could have gotten worse. On June 11th of the same year in 2009, the WHO signaled that a global pandemic of the 2009 H1N1 was underway. This prompted a worldwide response of the H1N1 pandemic, and this lasted for about a year and a half until the pandemic died down, because it usually lasts for a year or so. I remember in 2009, I think I was in high school when we got swine flu vaccinations on top of our already seasonal vaccines, because apparently they weren't as effective. So that was a big deal. And that was the latest pandemic, quote unquote, pandemic event that we've had here in the United States. So now, for the federal agencies, in order for us to plan pandemic influenza, prepare for it, there needs to be a trigger of when an influenza response is prompted. We can't just respond to an influenza outbreak if there is one or two cases in the National Capital Region. It's not reasonable to do that. In the United States, we both use the WHO pandemic phases and the CDC pandemic intervals framework, or the PIM. So you can see here the image for the WHO pandemic phases. So it's got 4 phases that includes interpandemic, alert, pandemic, and transition. And you can see they actually updated this a couple years ago because it wasn't really helping. The old phase wasn't really helpful, so they updated it with this different phases. And you can see on the right, it used to be just numbers and it didn't have the pandemic alert period and all that stuff, but now it does. So if you can see here, For example, in the National Capital Region, if we have, let's say number 3, human infection with a new subtype, but no human-to-human spread, or at most rare instances of spread to a close contact. That is a level 3 under pandemic alert period. So that's when we would start preparing for a pandemic event, but not necessarily responding, but preparing, having all of our PPEs, having all our antivirals ready to go, and having employees, make sure employees have their telework agreements so they could work from home. And if we look at level 6, which is the pandemic phase, increase in sustained transmission in general population, this is usually when we would start ramping up our response. We usually ramp up our response to pandemic even before the pandemic period hits. So with that, we usually follow the CDC guideline better than the WHO, because the WHO focuses on an international setting. So that's kind of harder to detect if there's a lot of people and a lot of areas involved. So we usually use the pandemic intervals framework from CDC, which is what we use at NIH. So part of my job at NIH for pandemic planning is I created the agency's pandemic influenza plan. So how we are going to function as a federal agency during a pandemic event. Agencies such as NIH, like my agency, we have the capability to assess what kind of response we must do in order to protect our employees and in order to keep our mission as a federal agency. The PIF also helps with the state and local agencies with how they will respond to a pandemic. So actually, if you look up online and look up the pandemic intervals framework, it has very, very helpful guidance for federal agencies on what they're supposed to do during a certain CDC intervals, and as well as state and local agencies. So this has been really helpful with our pandemic planning, and it's what we rely on when it comes to the triggers of a pandemic event. So now, for pandemic planning in the federal level, it will vary between different agencies. Federal agencies may take different responses and approaches to a pandemic event depending on the area they are in and where their employees are. So with NIH, most of our employees are located in Bethesda, Maryland, outside of Washington, D.C., but we also have a very large population in North Carolina, and also a large population in Montana, where our BSL labs are kept. So that's something we need to consider when we're doing pandemic planning, is making sure that we also know what's going on in North Carolina and Montana. The most common response will be social distancing in order to prevent the spread of the disease, and encouraging employees to work from home and consult their physicians if they feel that they have contracted the disease. Another mechanism can also be the dissemination of vaccinations to employees. This process can occur through close point of dispensing or CPOD sites. It's called CPOD sites, so that's something that I also work on with my agency. Many large federal agencies in the National Capital Region, so that's the DMV area kind of, are CPOD partners. So NIH is a close pod partner, so is Walter Reed Hospital, so is the United States Coast Guard. Any federal campuses, or when we say campus, we're talking about when we're occupying a large area. Any federal campuses that occupy a large area, we usually have a lot of employees, so we are close pod partners with the county and the state. This means that the county will distribute medical countermeasures from the strategic national stockpile directly to us so that we can decrease the burden from the open pod sites. The open pod sites are available to the public. So if there's mass vaccinations that happen, usually the public will go to open pod sites. And if we can decrease the burden with going to our own pod site, and that will help the public respond to the pandemic threat. There are a lot of regulations that involves our response to pandemics. These are some of just the regulations that we have in our policies that we use on a daily basis, that we always use as guidance. They assist us with the declaration and the response to a pandemic event, and you can actually find more online if you do a lot of research on it. And these are just some of the documents that I personally are like my Bible. I have physical copies of these at my desk, so I can always refer to them. They're very, very important with pandemic influenza. Two of them came from the White House, so it's a requirement for every federal agency to have a pandemic influenza plan. Whether it's 20 pages, 5 pages, they need to have an influenza plan. After 2009 pandemic, every agency has to have a pandemic influenza plan. So you can see here we have an HHS pandemic influenza plan, and then there was another update in 2017. The bottom line is that something is being done, and we're always preparing for a pandemic, whether it will come or not in the near future, because we don't know when it's ever going to happen. And if it does, we want to be ready. Many individuals, like myself and other people that I work with, are working really hard to protect this country and to protect the public and to prevent another pandemic from hitting the United States. The biggest things that we do is surveillance. Surveillance and vaccine research still continues as more pathogens and viruses emerge from the environment, from out of nowhere, really. And all these documents are available on the internet for everyone to read, so that they can educate themselves and learn a lot more about pandemic influenza. Many federal agencies now are leaning towards making these plans unclassified so that the public can have access to it, especially the state and local agencies. They're very, very important for them to have access to these plans and documents, because they're actually the ones who will experience the impact of the pandemic first. And with that ends our lecture for today. If you have any questions.
Maggie, this is Gene Lingridge. That was great. Thank you.
Thank you.
Yeah, fantastic. So yeah, there's a lot of things rolling through my mind, but I'll ask one and then see if anybody else at Jen or other people have questions as well. So just there at the end, you were talking about the NIH pandemic plan.
Mm-hmm.
It seemed like most of the examples that you were giving had to do with NIH as an employer. And focused upon sort of the employee protection and the agency protection.
Yeah.
How much do you get involved with the scientific and public health planning that goes on?
So
response in that area, yeah.
Okay. I think your question is about the national level response. Is that correct?
Yeah, I guess so. Okay. Yeah.
So with NIH, so I don't want to like tackle emergency management because it's such a broad field, but within emergency management, we have different essential functions. Mm-hmm. So HHS is ESF 8, which is public mm-hmm. health and science. So HHS is the main lead for all public health responses. And within HHS, there's a lot of sub-agencies, and one of that is NIH. And NIH is mainly responsible for vaccine research. So we don't do a lot of national level response. So we don't really tackle into the national level response. That would be ASPR, which is the Assistant Secretary for Preparedness and Response. So they do a lot of the national level response, and they actually deploy people overseas in other parts of the country to do a lot more data collection. But usually it's kind of political, but with NIH, we do what the secretary would task us to do during a pandemic event. There's no really set task for us, except NIH is a very science research heavy agency. And right now our plan focuses on the COOP, or continuity of operations of the government side of the agency, making sure that we are protecting our employees so that they can work towards the task that the secretary is making us do during pandemic events such as a pandemic event. Does that answer your question?
Yeah, it does. Yeah.
So it would be ASPR.
Right. Okay. Okay, good. Okay, so Jen said she's starting to lose her signal, so she's dropping off. She says, great job, Aggie, and I agree with that.
Thank you.
Yeah, so what about exercises? So you didn't really talk about exercises.
Yeah, I wasn't really sure because they're not really classified, but I didn't want to have them on the PowerPoint. But we do exercises every year in coordination with FEMA. Every year the scenario changes. Actually, this year is the lucky year. We are doing a pandemic scenario exercise. So that's going to test how HHS and all HHS sub-agencies are going to work together on a national level in order to respond to a pandemic, as well as how they're going to respond in order to protect their employees and how to keep the agencies working for their mission. And we're also working with FEMA and other agencies with that. So we are exercising every couple of years. It's just not every year.
Okay. Okay, good. But I suppose I'm not real familiar with the plan, the HHS or the NIH plan, but I suppose it does talk a bit about exercises in there, right?
Yeah, it's not available online. It's for official use only.
Okay.
So we can't really put it online. Otherwise, I get fired.
Okay, well, we don't want that to happen. You're one of our star alumni, so I don't want that to see that happen. Yeah.
Hopefully, like I said, someday they're leaning towards doing unclassified and like being able to share the plans with the public.
Right. So sort of yeah. So I guess just more general questions about your advice. So sometimes we have students who are interested in internships. So do you have advice for folks who are for students in terms of internships or courses or experiences that have been particularly helpful? So I guess one question is, do you take interns, and if so, how? And then the second question is, do you have advice for students in terms of furthering their career, using the courses to further their career?
Sure. Most of my recommendations would be focused on the Washington, D.C. area. I'm not really sure what the opportunities are outside of the DMV, the D.C., Maryland, Virginia regions, because NIH and the other agencies are in D.C. So if you are in the area, if you are a student, I would say, personally, and a lot of people would say, the easiest way to get into government is actually starting as an intern, being a student. So I started in the government as an intern, and I was, I was transitioned non-competitively to a permanent employee because I had a lot of training, and I have been working on the same topics for the duration of time that I was a college student. And then when I graduated, I was made into a permanent employee. So I didn't even have to compete with anybody. So I would definitely say if you have the opportunity to intern, I would highly recommend it, especially with the agency that is your dream agency to work for. A lot of the internships are paid. You can look at the pay scale online, I believe. If you have at least a year, I think if you're in your master's program, you're a GS7, which is about $45,000. I'm not sure what the salary is now because we had a little bit of a pay increase. So that's great. And if you graduate with your master's degree, you come in as a GS9, which is a pretty good, it's like about 56, 57. So it's a pretty good salary with like the DC area. I would recommend Taking the free online trainings, if you can find any, like a lot of those FEMA courses really help. Just knowing what it's like with like, there's a lot of Homeland Security courses that are free online. I took all of those as well because it's free. Any free resources you can find online. Also, networking and connecting with alumni and other people that are from the program, or just like honestly messaging a random person that you see that works at the agency that you're interested in, starting that conversation can lead to a job. That's how 2 of my jobs actually got to me in the past, because I asked for it. Sometimes they don't put it online, and usually a lot of the federal jobs, if you apply, they kind of already know who they want to hire. So if you have the ins and you know somebody and you network, your name can be on that list, and then you have the high possibility of getting the job and getting the interview. That's it.
Good. That's helpful. Very specific advice.
Yeah.
I guess so we do have our LinkedIn private group of which you're a member. So would you mind if folks messaged you through that mechanism?
Yeah, sure.
Okay, because that's, it's a private group, so it's just for alumni or students or faculty, so.
Yeah, I've actually had a couple students reach out to me, and I've helped them with their resumes, and actually one person got into the internship.
Oh, great.
Yes, and then other people have gotten into internship within HHS. There's a lot of internships, and they're just looking for people to come work. They're like a lot of the science agencies are really good agencies because we're very focused on science and preparing for events. Yeah.
Yeah, that's great. Yeah, we last month we had a fellow from FEMA talking about internships and entry.
Oh, cool.
Well,
I was just there today.
Oh, you were?
Yeah.
Well, I expect you're probably there a lot.
Not really. Like, yeah, they're right next to HHS.
Okay. Huh. Good. Okay. Well, I'm kind of out of questions now, and we're also getting close to 9 o'clock here, which is what we said we would do. So, Jen, anything else from you? I can read your chats. I don't know if we can hear you or not.
I'm going to try this and hopefully it works. Can you hear me?
Yeah, I can.
Okay, great. Aggie, thank you so much. That was super helpful. And I was able to hear you answer my question about how you got to the NIH for genes. So thank you very much. The only other thing I was going to add was, again, have a great summer, and we'll see you back in September.
Great. Thanks, Jen. Thanks, Aggie. Have a good night.
Thank you. Have a good night.
Bye-bye.